Hello, ladies and gentlemen. I'm very keen to welcome all of you in this webinar addressing the issue of hemostatic and sealant in thoracic surgery. It will be an international overview, and it seems a little problem, but it has a great area of uncertainty because most of the people really do not know the real significance of the drugs we use. How big is the issue? We know that up to 50% of patients experience air leaks after lung resection, even if most of air leaks stop spontaneously after a few hours or up to 3 days. The classification is, this is the standard, the old classification, because there is the Serfolio, because this classification takes into account what happens during forced expiration only, there is a bubble in expiratory only, inspiratory only, or continuous bubbling in air leak chamber during inspiration and expiration. Another classification takes into account the number of bubbles. So this classification seems to be, I can say, an old style classification. Now it's changed, and so we have understood that water submission test is a subjective assessment and depends on the individual surgeon experience. Now we can evaluate with the standardized method with mechanical ventilation how big is the air leak, below 100, between 100 and 400, more than 400. Otherwise, in the post-operative period, we have digital air leak monitoring, which can give us a good idea of what is no air leak. That is, according to the literature data, below or equal to 20 milliliters per minute. So it seems clear that air leaks is a multifactorial problem because it affects the patient with prolonged hospital stay, and it means an economic cost. It has patient satisfaction because patient is always asking if he can be discharged, and of course, worse outcome. So because the patient is not happy about a prolonged stay. So so it seems to be an important problem, not a minor problem. And it's important to say that even the Italian Society of Thoracic Surgeons has understood and has sent to all of us, I've just received now, a Delphi consensus regarding the use of hemostatic sealant. And of course, I voted that I ask all of you to take part in this consensus. At this time, I'm happy to leave the podium to the moderators. There are Franca Melfi, Chief of Robotic Surgery in Pisa and President of the Società Italiana di Endoscopia Toracica, and Professor Giovanni Moriana, former Chief of Thoracic Surgery in Mantua and President of the Società Italiana di Chirurgia Toracica. Please, Giovanni, it's up to you.
Good afternoon, everybody. It's with great pleasure that I bring the greeting of the Italian Society of Thoracic Surgery and mine to this meeting of Haemostatics, organized by Giuseppe Cardillo, that I thanks. The meeting sees the participation of many international experts who will surely shed some light on this fundamental topic. Naturally, I agree my co-moderator, Professor Franca Melfi, President of the Italian Society of Thoracic Endoscopy. I pass the word to Franca for the presentation.
Thank you, Giovanni. Good afternoon to everybody. It is a very pleasure also for me to be here, and is a really great honor to moderate this webinar, which has been so nicely organized by Giuseppe Cardillo. Giuseppe will be the next president of the Italian Society of Thoracic Endoscopy, of which I have the privilege of being the president and the pleasure to representing during this webinar, this fantastic webinar. So at this point, I would like to introduce immediately the first speaker. And just before I would like to recommend to send your question at the end of each presentation. Obviously, send a message to Q&A. You will find this in the box, in the specific box of Q&A. So the first presentation will be done from Francesco Carleo, and the topic is the Haemostatics and the Sealants, systematic review and meta-analysis. Please, Francesco, you can start.
Good afternoon, everybody. I thank Professor Melfi for the introduction, and thanks Giuseppe for giving me the opportunity to talk about this topic that's always being debated among thoracic surgeons. Now I share my presentation. It's okay? Everybody see? Okay.
Yes, Francesco, it is, I see this and I believe that
okay.
Mm-hmm.
Let's begin with hemostatic agents. We all know that meticulous surgical technique, as well as an optimal anesthesiological support, represent the key points for bleeding control. And in case of bleeding, the use of allogenic transfusions is mainly associated with immunomodulation, infectious risk, and high economic impact, which increase hospitalization. So several products has been proved to improve intraoperative bleeding control. However, variation in their use exists because practice guidelines reflecting the current medical evidence have not been developed. Topical hemostatics can be substantially subdivided into non-active, which do not contain clotting agents, and active, containing agents involving in blood clotting, providing thrombin at high concentration at the bleeding site, with directly converts fibrinogen into fibrin clots. And there is also another group of flowable agents, such as FlowSeal, with characteristics common to both categories. To address the need of the best surgical practice of topical hemostatic agents, the Society for the Advancement of Blood Management convened an international hemostatic expert panel in Washington, D.C. in April 2015. And this review, whose article included I show you, is its report. The RCTs referred to have all been performed in cardiac surgery or vascular surgery. The first one that you see is about the comparison between the topical human-derived thrombin, Evitrom, and bovine thrombin. Similar hemostatic success rates were reported, but the higher rate of antibodies in patients treated with bovine thrombin is the most important data to outline. Mechanical agents, for example, collagens, oxidized cellulose, gelatins, form a physical matrix providing a barrier over the bleeding site, activating the extrinsic clotting pathway and providing additional scaffolding for platelet aggregation to accelerate clot formation. The trial of CELAC as you see, the efficacy of this trial of microfibrillar collagen power collagen and oxidized cellulose surgicel in cardiac operation with a predicted high risk of bleeding was compared. And and statistically difference in favor of collagen group were recorded for chest tube drainage in the first 24 hours and total post-operative chest drainage. But the most interesting fact was the blood loss in the first post-operative hours that was significantly less in the collagen group. Now move on synthetic sealants, which are commonly used to prevent suture or bleeding in cardiac and vascular procedure by forming a watertight barrier over bleeding sites. Several studies have demonstrated their efficacy. In a Glickman study, comparing a polyethylene glycol sealant, COSIL, with gel foam in vascular anastomosis, the proportion of patients achieving immediate hemostasis with this sealant was 47.9%, which is lower than the 55% observed with cyanacrylate surgical sealant in Lambsden's study. However, in this last study, there are a number of problems with the study design. First of all, more controls received aspirin. Second, more controls had taken antivitamine key antagonists before the trial. And third, intraoperative heparin dosing was not standardized, and the use of protamine was left entirely up to the decision of surgeon. Flowable agents, as I said, combine mechanical and active agents and work by promoting thrombus production at the bleeding site. Flowable agents can be divided into bovine collagen combined with human pooled plasma thrombin and animal source gelatin combined with recombinant human thrombin. Data assessing the role of topic hemostatic in general thoracic surgery are limited. This prospective randomized study is, as far as I know, the only in thoracic surgery, and it was designed to assess the safety and the efficacy of FlowSeal in major lung surgery. As we see in the slides, patients selection was very strict. For example, we note a low percentage of patients with COPD, cardiovascular disease, and preoperative antiaggregation. And about the results, the author reported higher successful hemostasis rate for FlowSeal, a significantly shorter chest drain duration and in-hospital stay in FlowSeal group was seen, has been seen. But main limitation of this study include the subjective estimation of intraoperative bleeding, the inability to perform a blinded evaluation of intraoperative hemostasis, and the possibility that clinical factors other than hemostatic control might influence the postoperative outcome. Now let's talk about fibrin sealants, which contain fibrinogen and thrombin to aid in clot formation and are delivered as a liquid or patch and derived from three sources of fibrin: human pooled plasma, individual human plasma with bovine collagen and thrombin, and pooled human plasma with equine collagen. There is an abundance of RCTs addressing the use of fibrin sealants in cardiac surgery, although most have small sample sizes. 7 RCTs of fibrin sealants in cardiothoracic surgery suggested they were generally effective. Minato, for example, demonstrated in patients undergoing surgery for aortic dissection that the rub and spray method involved manually rubbing the sealant over the needle holes and then spraying the sealant over the anastomotic sites may also be important in reducing bleeding from needle holes. Maisano, comparing Tacosil, a collagen patches coated with fibrin sealant, with a standard hemostatic fleece material with no additional active coagulation stimulating substances, and showed significantly faster hemostasis with Tacosil, and post-hoc analysis revealed significantly more patients in the Tacosil group achieved hemostasis when the bleeding site included a vessel or heart tissue at 3 minutes. Those are other 2 RCTs of fibrin-based sealant. The study conducted by Lowe is interesting because the comparison of the fibrin-based sealant produced by virally inactivated plasma with a non-virally inactivated showed very similar hemostatic success rate and safety. The International Hemostatic Expert Panel developed this algorithm after answering to this question: do the coagulation status is intact? If it's yes, but we have an high anticipated risk of bleeding, it's reasonable to apply synthetic sealants to anastomotic and sutural site, like albumin and glutaraldehyde and PEG polymers. If we do not think it will be risk of bleeding, but finally there's a bleeding, we can use mechanical agents. In case of patients with coagulopathies or under anticoagulation therapy, the expert propose 3 scenarios, as you see in this picture. Maybe for thoracic surgeon, the second scenario is more important. The first scenario is more important. And when the bleeding is diffuse and is greater than 1 to 2 centimeters in diameter, for example, bleeding pulmonary parenchyma, and it is reasonable to use fibrin. So in conclusion, uncontrolled bleeding can have significant clinical and economic impact. The use of topical agents is associated with some risks, such as antibody development and transmission of viral infection. Active and fluid hemostatics produce higher hemostatic success rates than mechanical hemostatics and have the advantage of being versatile and are top-notch in patients with intrinsic coagulation problems. Move on to coverage of sealants for LX. Prolonged alveolar LX, as Professor Cardillo said, is the most common complication following pulmonary resection. We also know the economic impact related to, and high volume thoracic surgical institution report a PAL incidence of at least 15% annually. Basically, sealants for LX are divided into large families. The synthetic ones based on PEG, and those biological albumin based, such as BioGlue and Progel, and fibrin based, which can be of human or bovine or equine origin. This is a systematic review published in 2010. Here we are, the trials of fibrin glue included in the systematic review. In terms of LX duration, 3 trials did not find any statistically significant differences between treatment patients and control: Fleischer, Moritznen, and Wong study. In Fabian trial, a statistical significant difference was reported, 3.1 versus 1.1 days. However, the reduction in post-operative air leaks did not translate into any significant differences in the duration of hospital stay. In VivoStat study, although results for these parameters favored VivoStat, no statistically significant differences were found in terms of air leaks duration and days hospitalization. Lang in his study investigated Taco Comb, which is an absorbable patch consisting of an equine collagen fleece coated with human fibrinogen and human thrombin. Instead, Tacosil, a further development of a taco comb that does not contain any other component than human fibrinogen and human thrombin, was used in 3 studies. 2 trials, Anneg and Droghetti, have found differences in duration of hospitalization. The difference in mean hospitalization days did not achieve statistical significance in Droghetti's trial. However, it was shorter in the treatment group than in control group. As regards to synthetic sealants, Macchiarini and Port investigated the use of Advasil, an absorbable biomaterial consisting of 2 components, a primer, which is PEG, and the sealants forming by photopolymerization an electrostatic hydrogel patch. Although treatment groups have gone better than control groups in terms of air leaks duration and days hospitalization, there was no statistical significant difference. In Port's trial, Advasil reduced the mean duration of hospital stay was not different in the control and treatment groups, mainly because of higher percentage of empyema in the treated group. Empyema could be produced because this sealant did not maintain its adhesive properties over time and acted as a foreign body in the pleural space. Bioglue was used in 2 trials, one of which was Allen's trial, that is the only study with a shorter hospitalization for patients who had sealants applied compared with control. Nevertheless, there is no any difference in chest tube duration. This could be due to several reasons. First, patients with air leaks may be kept in the hospital for observation 1 more day after the chest tube is removed. Whereas if the chest tube is kept just for high volume drainage, patients may be sent home immediately after removal of the chest tube. Second, more Heimlich valves were used in the sealant patients, 10% than controls, 2%. And third, the measurement may not be sensitive enough because the autos measure chest tube duration by days and not by hours. In 2018, a systematic review and meta-analysis of RCTs was conducted on the effect of intraoperative polymeric sealant use on air leaks, empyema, and days of hospitalization. For a qualitative review, the search strategy yielded 21 RCTs reporting polymeric sealant used in lung resection, 19 of which were included in meta-analysis. There are all 21 RCTs considered. Synthetic polymeric sealants were used in 6 trials, fibrin-based sealants in 13, and other biologic albumin-based sealants in 2. Most were open, that is, the experimenter knew the assignment group. It is unclear in most studies whether the study participant knew which treatment arm they were assigned to. To quantify the presence and severity of air leaks, most studies use the analog chest drain system. Compared to digital chest drain systems, there is greater inter-observer variability in assessing air leaks in analog systems. The forest plot of air leaks demonstrated that 12 RCTs contributed to the meta-analysis of the effect of the glue on the probability of air leaks. The pooled odds ratio was 0.549. Heterogeneity, that is discordance between studies, was low. That means trials demonstrating a therapeutic advantage of the experimental treatment and other demonstrating a therapeutic advantage of the control treatment. Publication bias assessment with a funnel plot revealed a lack of large studies with high precision. As for data of the average difference in hospital stay, 9 RCTs contributed to the meta-analysis of sealant effect. The aggregate mean difference for hospital stay was approximately 1 day less in hospital for treatment patients. However, the heterogeneity between studies was very high. Publication bias assessment with a funnel plot revealed most studies contributing to the days hospitalization estimates were larger studies, possibly with higher precision. Additionally, the funnel plot revealed several outliers, making it appear asymmetric despite higher precision of individual study. So, summarizing, in terms of duration of air leak and permanence of chest drainage, there was strong evidence of a shorter duration of 1 day with sealant. However, in both pooled analyses, there were very high level of heterogeneity between RCTs. Moreover, different procedures included in the pooled analysis: wedge resection, segmentectomy, lobectomy, bilobectomy, although representative of thoracic surgical clinical practice, may also be a source of inter-trial heterogeneity. Reason for the lack of statistical significance in many individual RCTs on days hospitalization, in contrast to this pooled analysis, are likely multifactorial, because most air leaks after anatomic pulmonary resection are clinically innocuous and non-prolonged. They are managed conservatively with routine chest tube drainage. And study site differences in postoperative patient care and chest drainage management may also have contributed, as these algorithms were not included in many protocols. For instance, several trials suggesting placing chest tubes on water seal may resolve air leaks more rapidly than suction, and this may in turn affect when a chest tube is removed and patient discharged from hospital. In addition to lack of precision in post-operative chest tube management, the lack of effect on days hospitalization may be simply due to insufficient statistical power to detect a meaning difference in a secondary outcome measure for individual level RCT data. And finally, the meta-analysis for adverse events, as you see, did not reveal an increase in probability with a very low heterogeneity. So in conclusion, based on the data of literature, the value of topical agents is accepted, regardless of whether these agents actually contributed to local hemostasis and aerostasis or merely allow time for activating tissue repair system of patient. We all use them. Several options are currently available and every surgeon has a favorite. However, no agent has emerged as clearly superior in terms of rapid repair, ease of use, low cost, and minimal toxicity. Thank you for the attention.
Thank you, Dr. Carleo, for your clear and good presentation. I agree your conclusion about hemostasis. Generally, hemostasis is a physiological response to a tissue injury that also involves the vascular system and both the topical and systematic medical surgical intervention. But the fundamental objective to the treatment on hemorrhagic patients or who has blood loss is the restoration of the hemostatic balance. Now I'm going to introduce the presentation of Alessandro Brunelli, who will speak about risk factors of intraoperative air leaks. I recommend the time of the presentation.
Thank you very much for the kind introduction. I will try to remain within the times and gain some time. So I will discuss a bit about risk factors for intraoperative air leak. These are the figures from the last ESDS database. The incidence of prolonged air leak after lung resection didn't change much over the years, and it is about 10% after lung resection as reported in the database, but in real life it can be even higher. And of course, a prolonged air leak influences an increased postoperative cost by prolonging the hospital stay, perhaps being associated with other complications. And we recently found that a prolonged air leak is not only associated with the actual index postoperative cost, but increase also the 90-day postoperative cost due to frequent readmission or clinic visit or hospital or emergency department accesses. So actually the relative postoperative cost, those between the discharge and 90-day after operation account to 60% of the total 90-day postoperative cost. So it's not just an increase of the hospitalization cost, but also of over an extended period. In fact, a prolonged air leak is associated with an increased risk of empyema, especially when it is longer than 7 days. We know that 30% of all readmission within 90 days after a VATS lobectomy, for instance, are linked or associated with some chest drain problems. And the incidence of 90-day readmission after VATS anatomic resection in patients with prolonged air leak was in our series 24%, which is very, very high, especially in this group of patients with undergoing minimal invasive surgery, in whom the expectations of a fast recovery and a positive outcome are very high. Obviously, patients with prolonged air leak stay in hospital longer, and this is not always expected, because it is, for instance, our common habit to connect the drain to a portable device after 4 or 5 days, and we propose the patient to go home with the chest drain. But still, those with prolonged air leak have a 4 days longer hospital stay, and this is explainable by the fact that sometimes patient with a minor small air leak, we prefer to keep it 1 day longer to see whether the air leak stop or not, rather than sending the patient home with the chest drain, because we have realized over the years that sending the patient home with the tube is only good for physicians and surgeons, but not as good for patients. And in fact, of those discharged home with the drain, 24%, 23% were readmitted, and those readmitted were readmitted for instance, pneumonia, expanding pneumothorax, empyema, drain displacement, etc. So all problems linked to a persisting drainage with a prolonged air leak sent in the community. Obviously, the burden of air leak has been investigated by several authors. This is, for instance, a recent paper from the Premier database, which is an administrative database, not a clinical database. They found that the occurrence of any air leak complications, the definition includes prolonged air leak, but also pneumothorax, increase the length of stay in all type of resection. Increase is associated with increased mortality, again in all types of resection, and increase the hospital cost. This applies for wedges, segmentectomies, and lobectomies. It is not surprising that being so important under a clinical and financial point of view, there have been several papers trying to isolate, identify risk factors associated with prolonged air leak. The main reason to identify risk factors is to stratify patients at increased risk and possibly adopt and use a preventative measure to minimize the problem. This is an old study we published in 2004, and we found that several patient-related and surgical-related factors were associated with a prolonged air leak, which at that time was defined as longer than 7 days. But at the end, we were able to develop a model. You see here the bootstrap resampling statistics. The 3 most frequent variables were the presence of pleural adhesions, a low PPO FEV1, and an upper site of resection, like an upper lobectomy. So these were the 3 most consistent variables in all bootstrapped models. These patients were patients undergoing lobectomy through an open approach at that time. And you will see in the following studies that more or less these factors recur. This is a paper published in JTCVS on 350 patients. The incidence of prolonged air leak was 18%. Again, 46% were discharged with the chest tube, and you see the readmission rate was similar to our series now, 25%. The risk factors most commonly associated with prolonged air leak were the presence of radiological features or signs of emphysema, a reduced FEV1, and a lobectomy over a segmental resection. And the other interesting factor is the type of complications associated or in the group of patients with prolonged air leak were slightly different than in those without prolonged air leak, mainly pleural complications. So having an air leak or prolonged air leak and a persistent drain is certainly a risk factor for other complication, namely pleural base like empyema and chest infection. This is a large study from the EPITHOR, the French national database, and the authors tried to develop a model for predicting prolonged air leak on 24,000 patients, and then validate on another group of patients operated the following years. Their incidence of prolonged air leak after 7 days was remarkably low, so only 7%. But they were able to identify more or less the same risk factors, like, for instance, a male gender, a low BMI, and the presence of pleural adhesions, lobectomy over a smaller resection, and the upper side of resection. And they devised basically a risk score based on the coefficient, the value of the coefficient in the regression, a proportional risk score, and divided the patients in risk groups. And you see how well the risk score stratify the occurrence, the prediction of the occurrence of air leak. Using a similar methodology, we try to develop a much simpler score using basically two risk factors, FEV1 and presence of adhesions. You see here some examples, practical examples of a patient with a very low FEV1 with no pleural adhesion would have 19% of risk of prolonged air leak, but a patient with a FEV1 of 40% and reduced pleural adhesion can have a risk of as high as 37%. Whether this will apply or is applicable to minimal invasive patients remain to be demonstrated, especially in relation to the pleural adhesion, because now it is probably less blind to dissect adhesion compared to the open approach using the camera and energy devices. This is the most recent model we published in 2010 in the group of patients operated through an open approach before moving to UK. And we this is a multi-center analysis using 650 patients as a derivation group, and then these models was validated in an external sample of patients operated in another center. The incidence of prolonged air leak greater than 5 days was 13%, and the risk factors were age, a low BMI, which is quite consistent and also scored very high in the regression, a reduced FEV1, which is a marker of compromised respiratory function and frail parenchyma and COPD, and again, pleural adhesion. And we grouped the patient in 4 classes of risk, and you see here how well the score stratified the risk of occurrence of incidence of prolonged air leak, both in the derivation and validation set. Similarly, other authors have proposed other easy risk scores. But again, you know, you see the low BMI, the gender, and in this case, history of smoking, and compromised respiratory function like reduced DLCO are obviously associated with prolonged air leak, and the model was quite discriminatory with a C index of 0.8 in this population. This is one of the most recent risk models published in the JTCVS in 2017. and it is based on 2,300 patients undergoing lung resection. Prolonged air leak was 9%. Obviously, it was associated with a much longer hospital stay, 6 days longer on average. Again, low BMI, low FEV1, the type of procedure, and the side, the smoker status were associated all with the prolonged air leak. And then the authors were able to develop a nomogram assigning points depending on the value of the different variables associated with the prolonged air leak, and divided the patient in low, intermediate, high risk depending on the total score, and the observed and predicted frequency were quite similar. And this is the model proposed by the STS from the STS General Thoracic Surgery database. 52,000 patients undergoing lung resection. Again, the incidence of prolonged air leak is very similar to the ESTS, to the one observed in the ESTS database, 10%. And again, low BMI, lobectomy over lesser resection, low FEV1, male gender, upper procedure. So you see here that these variables recur. They are quite consistent in all studies. And obviously, those patients with prolonged air leak had a prolonged stay, were discharged more frequently with the chest tube, and had a higher rate of readmission compared to those without at lower risk of prolonged air leak. This is a meta-analysis of factors associated with prolonged air leak. You see upper lobectomy, BMI, quite consistent. BMI or low BMI is probably a marker or a surrogate of other variables which are more associated with sarcopenia or a low protein level and a reduced capacity of repairment and increased frailty that expose obviously to low healing process in the lung after resection. Age and pleural adhesion as well, and you see all the other factors which we have seen before, right-sided, reduced FEV1 to FEVC ratio, so COPD basically, and thoracotomy over minimal invasive, although we'll see this is not consistent, and lobectomy over lesser resection. When we compare VATS versus open, to be honest, we didn't find any difference in incidence of prolonged air leak. So VATS or robotic is not protective compared to thoracotomy, and the incidence of prolonged air leak through the two axes is basically similar. So the problem still remain even if we perform more and more minimal invasive procedure. This is why we recently try to verify or identify or develop a model to predict prolonged air leak after VATS lobectomies from the ESTS database. So more than 5,000 patients submitted to VATS lobectomy for cancer. You see here the variables that came out after logistic regression, the gender, a reduced FEV1 and a low BMI again. Not surprisingly, not different compared to open scores, developed based on open resection. And then the variables were scored, proportionally scored based on their regression coefficient. The majority of patients were in class A and B. which were the classes at lower risk, but about 25% were classes C and D, at the highest risk of prolonged air leak after VATS lobectomy. And you see class C and D had a very high incidence, class C 13%, class D 25% in the derivation set, about 18% in the validation set. And we further validated this score in our population in Leeds on 350 patients submitted to VATS lobectomy segmentectomy over 2 years with a prolonged air leak incidence of 15%. You see patient with prolonged air leak have increased cost, and as well as those patients discharge home with a tube. So if we think that discharging home a patient with a tube is cut cost or save money, this is not always the case. These patients, they still stay in hospital a little bit longer than patients without prolonged air leak, and they tend to come back more often after discharge, increasing cost. The patients were then grouped in 4 risk classes according to the ESDS PAL score we have seen before. 20% were in classes C and D, and they had on average $2,000 higher postoperative cost compared to classes A and B. So the score could be useful also to predict financially the financial outcome of patient with the prolonged air leak. And after excluding the patient admitted to ICU or with other cardiopulmonary complications, the duration of air leak still remain the only factors associated with postoperative cost. Each day of air leak would increase the cost by approximately $150 compared to patients without air leak. And I like to also show this paper, which is basically a validation of 4 of the several risk models we have seen before in patients registered in the Italian VATS group registry. The PAL definition was 5 days. So basically the authors tested these 4 PAL risk models, recalibrating the models on their on the population registered in the VATS, in the Italian VATS database. And what they found is basically that the decision curve analysis showed that all models have almost no net benefit when the threshold probability is greater than 0.30. So predicting a prolonged air leak after VATS using risk scores is, yes, is possible, but with a high rate of false positives. So this may have may be important when deciding to use risk score to select patients or which patients could benefit of preventative measures like sealants, for instance, or other measures. We now have a growing interest in doing sublobar resection like segmentectomies, and the majority of studies didn't find an increased rate of air leak after segmentectomies compared to lobectomies, with the exception of the yearly outcome report from the JCOG randomized trial in 2019, and they found almost 2-fold higher incidence of PAL compared to lobectomy. But the incidence of prolonged air leak after lobectomy was very, very low. And please keep in mind that this is a population of fit patients in a randomized trial. Air leak can be estimated intraoperatively, and this is something we have done in 2017 on about 100 patients undergoing pulmonary lobectomy. What we did was to assess the air leak at the end of the resection using the spirometer of the ventilator and measuring the difference between the fixed inspired and expired volumes at standard tidal volume and positive end expiratory pressure. And we basically find a correlation between the air leak measured at the ventilator and the bubbling score. What we found as the best cutoff or threshold to predict prolonged air leak was 500 milliliter per minute. And in this group of patients, 55% developed a prolonged air leak, and they had a much longer duration of postoperative air leak compared to patients with an intraoperative air leak less than 500 milliliter per minute, which is more or less the same cutoff found in this more recent study, which is basically the 9.5% of the ratio between the difference between inspiratory and expiratory volume over the inspiratory tidal volume. So in conclusion, prolonged air leak remain a frequent complication after lung surgery and resection, and this is quite irrespective of surgical access or extension of resection. It is obviously associated with increased hospital costs, prolonged stay, and increased risk of other complications and readmission. Several patient-related factors have been identified over the years, and risk models have been proposed and can be used to stratify the risk of PAL. However, their cost effectiveness to select patients for preventative measures still remains to be proven. Thank you very much for your attention.
Thank you, Alex. Thank you, Alex, for this outstanding presentation, for this lecture, really lecture. It is fantastic. We decided to postpone our discussion at the end of the presentation. This was according to Giuseppe and my co-moderator, Professor Muriana. So I would like to introduce the next speaker, which is my good friend. It is a really privilege, my honor, to introduce Alan Siohe from Hong Kong. And the topic of his presentation will be Managing Air Leak, the story so far. Please, Alan.
Thank you so much, Franca. And thank you so much to Giuseppe Cardillo for inviting me to share with you today. So I'm going to talk about managing air leaks. So the whole point of this particular short presentation is as a bridge between the previous talk, where we've heard in detail about what a big problem air leaks, and leads on to the next talk following this, talking about sealants. So hopefully we're going to bridge that little gap by quickly listing all the different ways that we can manage air leaks today. Now, nothing that I'm going to say in the next 10 minutes is going to be news to any of you. So hopefully this will serve as a sort of a reminder or refresher course about all the different options or alternatives to using sealants. And you can make your own mind up about whether or not sealants are an improvement on what we already have. So these are my disclosures. One or two of these products by these companies might show up in some of these slides, so I will not mention any of them by name, and I will not promote these products. So we've already heard just now in Alex Brunelli's fantastic talk about the scourge of air leaks. It's a big, big problem. It's very, very prevalent. And today, in the age of VATS, it's probably the single leading complication after lung surgery today. It's more common than anything else. And we already know you can predict which patients might get prolonged air leaks. So what can we do about these? And should we do something about it? Yes, you should do something about it, especially after the last year, because in addition to all the other problems that we've already heard about from air leaks, early last year during the early part of the pandemic, some of our colleagues have already speculated that simply having this air leak into the ward environment could potentially be a source of spread of disease. So there's an added incentive for us to stop air leaks in this day and age. So what can we do about it? Well, this is the way I see it. You have an air leak, you see it on table. If you don't do anything about it, once the patient goes back to the ward of a chest drain, you get prolonged chest drainage. And if you sit on that, eventually you will have increased length of stay, complications, increased costs, et cetera, which means that there are two opportunities for us to treat air leaks. One, you can either treat it post-operatively when you see that you're having prolonged chest drainage, do something then on the ward. Or the other opportunity is to do something intraoperatively. We all test for air leaks on table, and if you see something there, well, let's do something about it. So let's talk about these two stages separately. Let's start actually with the post-operative interventions because it's relatively easier to talk about. So post-operatively, what do the textbooks teach us? What did your teachers teach us? Well, the simplest thing to do is play around with the chest drain, and all trainees in thoracic surgery know these things. You can shift the chest tube, move it out, maybe move around a little bit. Sometimes it works amazingly. Don't look for any studies on this. It's such a simple thing that I don't think anybody's ever going to do a randomized trial on this, but sometimes it works. And the other thing you can do with the chest drain, of course, is adjust the suction. Either take them off suction completely or play around with the levels a little bit. And I think most of you already are well aware that there have been studies looking at this. And just to sum things up, I think in general, it's been found that if you compare simple water seal with a bit of suction, there's a trend really for water seal alone to be better in terms of stopping air leaks and reducing chest tube drainage. However, I must say that the results aren't always consistent. I think you will always find individual studies which say the opposite. And even when we're talking about suction versus no suction, it's not 0 or 1. The difference is not like that. There's so many things in between, such as different levels of suction, such as intermittent suction, such as initial suction, and then you take them off suction later on. There are many variations. So I think the jury is still out. But I think generally, as you can see from a number of these meta-analyses, there's a slight tendency towards non-use of suction, I think, in some of these studies. Now, besides playing around with suction, what else can you do? Well, if you have a chest drain in these patients, of course, when they get back to the ward, everybody knows this, you can put something down that drain. You can either inject some chemical pleurodesis, an antibiotic, or God forbid, some talc. Or you have heard of these studies where you use autologous blood as a blood patch pleurodesis. So you just mix some blood with EDTA, shove it down the chest tube, and hopefully your air leak will stop. Now, I think you will find individual small studies that actually show this works. I do use these very rarely in my own practice, and they do sometimes work, or at least they treat the surgeon's anxiety. It means you're doing something rather than doing nothing. However, when you do use these two things and you're actually injecting something from outside into the patient's chest, you are causing pain. Don't underestimate it. Some of these antibiotics do cause pain. If you inject local anesthesia with your pleurodesis, that adds another level of complications in itself. And there's always a chance that you could be injecting microorganisms into the chest. So these work, but they do come with a little bit of a cost. Now, last but not least, I think a lot of you are aware that you can always send a patient home with a chest drain. And I think in Europe, you have more experience of this than anywhere else in the world. And it's been shown in several studies that this is cost effective, it works. However, as I'm very glad to hear Alex Brunelli say in his talk just now, again, this is probably treating the surgeon and the hospital more than treating the patient. I can tell you for a certain fact that in East Asia, whether you're talking about China, Japan, or Korea, no patient will want to go home with a chest drain. They refuse. I think in the last 20 years, I've sent maybe 2 or 3 patients home with a chest drain. Everybody else would rather stay in and have the drain removed, even if they have to stay in for over a week in hospital. So it's, in theory, it sounds good, but in practice, it's not always feasible. And as we've heard, even if you do manage to send your patient home with a chest drain, they can come back in with some complications. So these are some of the traditional textbooks methods of postoperative air leak management. But thankfully, in the last 10, 15 years, I think we've had two alternatives, or rather more sophisticated alternatives. One, of course, is the endobronchial valve. Now, this was originally developed for use in emphysema as an alternative to lung volume reduction surgery. And I think in Hong Kong, we were one of the earliest groups to present our early results of this. It's evolved over the years. You have newer generations of these valves, and these have been shown in some small-scale studies to be pretty good at stopping postoperative air leak. However, do be aware that these things are expensive. In my part of the world, putting in a full set of these endobronchial valves very often is as expensive as a lobectomy, sometimes even more expensive than the lobectomy. So you're treating a major surgery with something that costs quite a lot of money. And do be aware that every time you do bronchoscopy, there's a chance of complications. Every time you put these valves in, you will eventually have to do another procedure to take these valves out. And at the end of the day, if you put these valves in, you are ultimately stopping ventilation of part of the lung in which you've already resected a lobe or a segment. So you're not really doing the lung function any good favors. So endobronchial valves, yes, they're available. And if you have a big problem with air leaks, this is an alternative. But the fact is, logistically and financially, they're not very viable in many centers around the world. Now, the other introduction of technology, I think, which certainly I think many of you in Europe are already using, of course, is digital chest drainage. There's not enough time in this particular short talk to go into all the different reasons why digital chest drainage can help with air leaks, but they do. This has been shown in several prospective trials, including randomized controlled trials. And it's been shown fairly consistently that use of different digital chest drain systems with a sort of a controlled negative pressure actually is favorable in terms of reducing air leak durations, in reducing chest tube durations, and ultimately in saving costs. Now, you can go to each of these individual studies in turn, but I think, well, whether or not there is publication bias, nonetheless, there is good published evidence that these systems actually may or may not work. We've actually validated this in China very recently, a multi-center prospective database in China. We've also validated this even in an Asian population. So consistently, we're finding shorter chest drain durations. One of the reasons for earlier chest drain removal might be because you're having a more objective assessment of postoperative air leak. And if you have a more objective assessment with less inter-observer discrepancy, you're probably more decisive and act quicker when you're making a decision on whether or not to remove the chest drain. But we'll come back to this in a minute. So these are all the options that you have available for post-operative intervention. But the problem with post-operative interventions, all of those things I mentioned just now, is that by the time you use these interventions, usually you've already had prolonged air leak and prolonged chest drainage, and you want to do something about it. So isn't it better to do something intraoperatively and forgo all of that post-operative air leak altogether? So conceptually, of course, it's better to do intraoperative intervention. That's the key. Now, if you want to do something intraoperatively, what can you do? Well, the first thing you can do is try and prevent air leaks from occurring in the first place. So you all know the things about good tissue handling, fistulous surgery. I think most of us today, we're very well aware, and we often practice this fistulous surgery. I think especially in the age of VATS, we often do that in the sequence of our surgery. We leave the fissure till last and you just staple it instead of dissecting straight through the fissure and causing raw areas that can air leak. You can use other things to reduce the chance of air leaks, such as buttress stapling. Now, this used to be quite common, I think, about 10, 15 years ago. I think there are some highly publicized incidents regarding some of these buttresses. These are well documented. And so I think in recent times, buttressing is, from my observations, a little bit less popular than it used to be, but it's still available. And if you have a very obviously emphysematous lung is still a viable option. Of course, at the same time, a lot of the manufacturers of staples are getting better and better at producing new designs of staples, which are said to reduce air leaks as well. So there are very still tricks you can use to try and reduce the chance of getting air leak. If you do get an air leak on table, what can you do? Well, the simplest thing is you can suture the air leak. But as all of you are well aware, you put in a suture in a lung and the lung reinflates. Sometimes the sutures cut through, it can cause air leaks in themselves. So traditionally, again, if you go back to the textbooks, they recommend two sort of things. One is maybe creation of a pleural tent where you remove part of the parotid pleura and you actually slap it onto the lung where you're seeing an air leak, and it kind of covers the air leak with the pleura. Or you can cause an elevation of the diaphragm. You can either use a phrenic crush or local anesthesia to the phrenic nerve, or you can create a pneumoperitoneum, which raises the diaphragm. And again, that's sort of abuts the air leak site. And both of these have been shown in small studies to reduce air leaks. However, most of you in the audience, I'm pretty sure, don't use these or use them extremely rarely. And of course, because today in the age of VATS, in the age of sublubar surgery, we're aiming for minimal invasiveness. And both of these are adding invasiveness and adding morbidity to surgery. So, you know, instinctually, you don't really want to do these things. I mean, pleural tent, it's a pleurectomy. It's painful, for goodness sake. So there's a good reason why we don't do these very often. So other than this, traditionally, you know, according to textbooks, well, you don't have that many other options for intraoperative intervention to reduce air leaks. And here is where we bring the story back to sealants. And that's why the next few talks after mine are going to be important. So hopefully what we're going to see is why sealants in this environment where post-operative interventions are probably a bit too late, and other intraoperative interventions are probably not ideal, then if you have a sealant, wow, simple solution, cheap and easy. You slap some glue onto the air leak and hey presto, you've solved the problem. So do these actually work? Now, we've already heard from the first two talks, actually, there's a lot of good evidence emerging that, yeah, actually, these might work. So you're talking about different flowable sealants. You're talking about mechanical topical patch agents, hemostats. And all of these individually have been shown, of course, yeah, to have some sort of effect. Again, we're talking about publication bias here. Now, if you're talking about the efficacy, and I mean, and you're saying, oh wow, there's so much evidence here that suggests it works. Why aren't we all using it? And a lot of it can be traced back to this Cochrane review. I think this, and whenever we talk about sealants, we very often go back to this particular study, this Cochrane review of 2010, and this is often quoted. They looked at 16 trials. With 1,600 randomized patients. And what they found is that if you use different types of surgical sealants, yeah, you can reduce the incidence of postoperative air leaks, but they were only significant in 6 out of 16 trials. And only 3 out of 16 trials showed that these sealants reduced chest drain durations. And only 2 out of 16 trials showed that the percentage of patients with leak was reduced, and very few of these trials actually showed reduction in length of hospital stay. So ultimately, the author's conclusion was that, well, we can't recommend you using these sealants. And this kind of conclusion actually is stuck with us for the next 10 years. So even today, we're kind of reluctant to use sealants in some hospitals. In fact, around about the time when this Cochrane review was published, the ESTS did a survey of surgeons. And so you can see here that the views on the use of sealants was very mixed. People weren't sure whether we should be using it. We weren't sure about what sort of situations we should be using sealants in. Now, things have changed over the last 10 years. And that's because I think we're gradually realizing that a lot of those early randomized trials that were included in the early systematic reviews in that Cochrane review, those initial trials were flawed. I think it's already been touched upon, I think, by Dr. Caleo, that some of these studies were small, they were heterogeneous, there was inappropriate blinding, not very good randomization. Very few of those early patients had VATs performed. But I think there were two major problems as well. One is the postoperative chest drain protocols in a lot of those early studies. For example, how many drains you put in, how much suction you apply, when you take them off suction, even when you remove the drain. Those weren't clearly defined in a lot of those early studies. So if you're using chest drain duration as an outcome measure, but you don't define your chest drain management very clearly in the methodology, that's going to compromise the reliability of your trial. The other problem, which I think is even bigger, is that a lot of these randomized trials, the early ones, go back to them, look at the methodology. They included patients that had no air leaks. So they had patients in both the control arm and in the intervention arms that had no air leaks. If you have a lot of patients with no air leaks in your intervention arm and in your control arm, then obviously that's going to compromise your ability to find a significant difference between the two groups. And that's why I think these early trials were flawed. And I think we're gradually having a greater realization of this. Another problem, which I pointed out in a commentary on another paper a short while ago, was that almost all of these early studies use as their final outcome measure in looking at chest drain durations, all they did was look for bubbling through the water seal. They don't even use some of the scoring systems that we heard about earlier. And you all know that observation of bubbling through a water seal chamber is extremely unreliable. It depends on how well the patient coughs. It depends on how well the patient's pain is under control. It depends on the experience of the observer, the nurse or your resident, and a lot of other factors. So if your final outcome measure, that step, is unreliable, the whole trial itself sometimes can get compromised. And with these sort of realizations, I think that's why we're moving on to these newer trials that hopefully we'll be hearing about in the next few talks. And you can see that some of these newer trials, including one by our president, Giuseppe Cardillo, actually looks specifically at patients with intraoperative air leaks. And this is the trend of more recent studies in more recent years. And we're getting better, more reliable results as a result. And that's why when you do a systematic review nowadays and meta-analysis, you're more likely to find good evidence that not only air leak duration, but also chest drain duration and length of stay can be positively influenced by the use of sealants. We're getting better results in that regard. And hopefully that's where we're going to move on to. So I'm just going to very quickly wrap up this talk. I think if you're going to manage air leaks, you can manage it post-operatively. There are various ways of doing it, including chest drain manipulation, digital chest drains, et cetera, but you're already treating something that's, well, the horse has already left the barn. Okay, so you want ideally to treat air leaks intraoperatively, prevent prolonged air leak in the first place. But the surgical options you have are not always ideal. And into this void, we have sealants. The early evidence led to mixed conclusions, mixed feelings by a lot of our colleagues around the world about using sealants. But as the science evolves over the last 10 years, we're seeing better research into the use of sealants for air leaks, including modified inclusion criteria, making sure that only patients with air leaks are included into these studies, and you're using better outcome measures, such as digital recording of air leaks. So with that, I'll end my talk, and hopefully that puts us in a good position to move on to the following talks, where we're actually going to see some good trials about the use of sealants. Thank you very much.
Thank you, Dr. Alan Shaw, for your good presentation. Very interesting presentation.
Thank you.
My compliments. And now I'd like to introduce Francesco Zaraca, who will speak about sealants in management of intraoperative alveolar air leaks, a multicentric randomized controlled trial.
Thank you, Giovanni. Thank you, Giuseppe. I appreciate the opportunity to share with you our experience on prolonged air leak. It's quite a difficult situation to speak after Alex and Alan. Anyway, I will try to give you some original few points. So the disclosure, I have no disclosure to report. So this was my quick overview, but the introduction is completely unnecessary, and I will go on quickly. Anyway, in a few words, of course, prolonged air leak has a high clinical and economic impact. So the patient selection, Alex gave us a wonderful speech about risk factors. And we are going anyway to publish in the next future the Italian VETS group score based on about 10,000 patients analyzing our VATS group registry. So this is our recent published paper that Alex showed us. And I repeat that after our external validation, at the moment, predicting a PAL after VETS lobectomy, analyzing only preoperative risk factor is of course possible, but is burdened by high rate of false positive. And as usually, Alex anyway understood what is the future. So according to our experience, one of the most important analysis is the intraoperative air leak. So the combination of preoperative risk factor with the intraoperative objective measurement of the air leak is, in our opinion, the future. And according to the recent published consensus of the European thoracic surgery, published always by Alex, revealed that sealant should be used only in high-risk patients when an air leak is seen at the end of the operation. So now we are going to analyze the 5W open question on prolonged air leak. What tool do we have to identify and quantify intraoperative air leak? Which air leak to treat and which treatment? And what benefit for the patient and what economic advantage? Those was the question that we tried to answer also with our randomized control trial. Intraoperative assessment, as said Alan, is of importance. And what tool do we have? Of course, an old classification, Macchiarini, that was 1999, and is of course a subjective interpretation. We have some new method using indiocyanine or surfactant, but those are anyway subjective interpretation. And we tried to define an objective measurement through the mechanical test ventilation with a volumetric constant flow. And though in the literature, we can find the two trial, one prospective analysis by Alex and our randomized control trial. And we were able to individualize and to classify, as Giuseppe showed us at the beginning, the patient in 3 classes: mild, less than 100 milliliter, moderate between 100 and 400 milliliter per minute, and more than 400. Which air leaks to treat? Always the same 2 trials. And what's the treatment? Alan showed us that intraoperative is very important. We have a different way to treat. And as I told you before, analyzing the preoperative plus an intraoperative objective air leak is the future to identify patient to treat intraoperatively. What we have, we saw at the beginning, the old Cochrane database from 2000 10, and we know that the conclusion is more and larger randomized controlled trials are needed. And a more recent review has the same conclusion. A standard method of air leak prevention and treatment has not been yet established. Benefit of this treatment. We have a recent randomized controlled trial, an Italian one, but after open lobectomy, a prospective and a retrospective study analyzing the Progel sealant and the conclusion that is significantly decreases hospital length of stay and hospitalization cost. And again, the economic advantage, if we analyze an assessment of the clinical and economic impact of air leaks during lung surgery, we can see that about 15% of in-hospital inpatient stays are from patients with an air leak. And as told us Alex before, the total hospital charges is higher of about 2,000 euros. Which evidence we required to say that is important to support the use of sealant. According to the consensus always by Alex, we say that sealant should be support to use sealant should come from randomized controlled trial, but also from real world data, therefore the registry. So now I'm going to present you the results of our randomized controlled trial. And this is the study group inside the Italian vets group analyzing the economical assessment of technology in vets. The aim of the study of our randomized control, multi-center randomized control trial is the economic evaluation of this sealant for intraoperative treatment of alveolar air leaks after VATS lobectomy. The study is spontaneous, independent, and no profit. The customer, the Italian vets group, and the coordinating center is Bolzano. And as I told you before, according to our mechanical test, we enrolled only the patient with moderate air leak. And this is the mechanical test definition. So we had two groups. Group A, patient where we applied the Progel sealant, and Group B, where we didn't apply treatment. Patients with mild air leak, less than 100 millimeters per minute, were not randomized because self-limiting. And the patient with the severe air leak, more than 400 milliliters, were treated and not randomized. Our flow chart explaining our study. So chest tube drainage management, as Alan told us, is one of the most important steps. We use always one chest tube drainage, 24 French coaxial thorax drainage, under suction only for the first 24 hours, and only in case of a symptomatic pneumothorax, a longer negative pressure was necessary. And the postoperative air leak were recorded by this portable air leakage monitor. This is the ethical committee. And this is those are the centers who participated to our multi-center randomized trial. Outcome. So primary endpoint was duration of air leak with this digital measurement. The secondary, duration of chest tube hospitalization, perioperative morbidity, readmission rate for pneumothorax at 60 days, and the economical assessment at the end. The sample size of the study was 25 patients for each group, according to the primary endpoint and the literature data, and we expected a standard deviation of about 2 days. The consort flow diagram. And we can see the demographics and clinical characteristics. We had no different, significant difference between the two groups. At the end, we have the 28 patients for the Progel group and 27 for the no treatment group. And this is the surgical and pathological data. The results. So we could demonstrate that after treating a patient with this intraoperative air leak between 100 and 400 milliliters per minute, the mean duration air leak was higher for the patients that were not treated. The mean time to drain removal was higher also for the patients that were not treated. And the patient treated by Progel had the mean length of hospitalization 2 days less than the other group. And we could demonstrate that in the Sealant group, we did not register any postoperative prolonged air leak more than 5 days. And 25% of the patients in the control group experienced a prolonged air leak. And the cost analysis revealed an additional cost related to the hospitalization higher for the control group. So in conclusion, objective measurement of intraoperative air leak by the ventilator, so plus the PEL predictive score is recommended in moderate leakage after vacillobectomy. The sealant, the Progel sealant, is safe and efficient. And compared with standard treatment, sealant significantly reduces postoperative air leak, time to drain removal, length of hospital stay, resulting in significant cost benefits. Thank you for your time.
Thank you, Francesco. It was a really interesting, especially this study. It was really, really interesting. So maybe we will have many points to discuss at the end of this webinar session.
Thank you.
In the meantime, so thank you. I would like to introduce one of the founder worldwide of the VATS major lung sections, Henrik Jansen from Copenhagen. It is my privilege to introduce him, and the topic of his presentation will be vacillobectomy segmentectomy. Is there a need for hemostatics and sealants? Copenhagen experience. Please, Henrik.
Well, thank you for the introduction, and for sure I would love to be in Italy to give the lecture instead of doing it over the web, but still we can discuss things. And actually, looking at the presentation so far, I think that maybe half of my slides have already been presented. So first of all, what are we dealing with both in bleeding and air leaks? While we're seeing this short, I have some disclosures. I'm a speakers bureau and advisor for those 3 companies. I do not think it is affected in my lecture, but anyway, it is mentioned. So this is a left upper lobe lobectomy, fissureless, and doing the posterior artery, a small branch, putting on a Haemolock clip, and then taking it with an energy-based devices. And you do see this oozing, this bleeding. So really, as a surgeon, stay calm and go on and be prepared to address it. You should always have a plan whenever you see a problem. So at the end, this one could actually be dealt with by the energy-based devices and didn't have any need for additional hemostatic agents. So in the good old days, you have huge thoracotomies. Whenever you had a problem, you could stick your head inside, deal with the problem, clamp the vessels or whatever, and try to stitch you out of the problems. But for sure, everybody of you know how would you like to have your chest dealt with, how would you prefer to having your surgery, and the difference in surgical trauma is obvious. There can be a lot of debate about how to do the VATS. This is the 3-port anterior approach, the Copenhagen approach that we have allocated and still do use. And I don't think for the topic of today that it is meaningful to discuss the number of incisions. The way you do it, the only thing is that you do proper minimal invasive surgery, no rib spreading. And that does also mean that you need to deal with your problems from outside with the VATS instruments. You cannot just put your hand inside, put big clamps inside and deal with things. We have in Copenhagen quite a huge experience in VATS lobectomies, and I just look at the latest data. We have done 10 more since I did this slide. So we are doing around 350 VATS lobectomies a year with a conversion rate of 1% nowadays in infants to elderly people. And looking at the data from last year, it's not published yet. We are now dealing with the lung cancer with VATS in around 95%. So really everything but vascular sleeves are done by VATS. And that leads to the present now that you can deal with redo lobectomies, patient with former chemoradiotherapy, segments, selected chest walls, selected sleeve resections, selected pneumonectomies, and minimal N2 disease. And lately, we started doing the first VATS lobectomies in patients who had former COVID-19 infection. I did a case a few months ago in a patient who had 40 days in the ventilator due to COVID-19 and had his lung cancer detected in this. And I must say, doing a surgery there was pretty much like doing surgery in a downstage patient, a patient who had like immunotherapy, also done the first cases with downstaging by immunotherapy and afterwards. So that's a lot of fibrosis, and you need to be ready to deal with that. You need to be ready to deal with the dangers in those procedures. Years back, we published this comparison of VATS versus open from Copenhagen. Until 2009, we had 2 units in Copenhagen, one doing VATS, the other one doing open procedures only. So you can compare the two groups, seeing that VATS was superior in blood loss, OR time, superior in number of lymph nodes resected, and shorter post-operative drain and in hospital stay. What's actually is more interesting is actually that the open group had significant more complications in all those conditions mentioned there, both the more benign small ones, but also severe one like ICU stay, sepsis, renal failure. And interesting is also that there were more nerve paralysis in the recurrent nerve, indicating that the surgery is more precise by VATS. Looking at complications, both minor and major complications, and doing an odds ratio on this, the conclusion were that for patients having an open lobectomy were more likely to have either a minor or a major complication when they had open surgery. And the single most important factor to predict complication was actually the way surgery was done. And this remained after adjusting for gender, age, lung function, cancer stage, year of surgery, and modified Carlson comorbidity index. And this was later on confirmed in other papers. Some of Bonelli's paper about developing the EuroLung papers from the European Society's database confirms this. Looking at complications, I would like to highlight this paper where several of you were also participating, looking at major intraoperative complications during VATS surgery. We need to learn from our failures. So we looked at the reason for conversion. There can be oncological reasons that you cannot deal with by VATS. You need to convert because you need to do extra resection, replacement of vessel structures or whatever. It can be technical reason that actually you cannot master it by VATS due to severe adhesions, hilar fibrosis or similar. And finally, what's interesting for this paper was complications by VATS surgery, where you needed to convert due to a major complication that we could not deal with by VATS. The intraoperative complications in this paper was defined as injury to the pulmonary artery, the vein, or branches of those which give a blood loss of more than 500 milliliters. And it also included life-threatening condition, the total blood loss of more than 2 liters, one transection of bronchial structures, injury to other organs, and intraoperative events that led to major other surgery, like doing a bilobectomy instead of a lobectomy, doing a pneumonectomy, And this was also redo procedures within the first month where the indication not was for oncological reason. We met in the study group 2 days in Brussels, seeing the study group here, and analyzed in detail. So in total, over 3,000 patients. The majority of the cases was done by really experienced surgeons in experienced institutions. The single institution should contribute. The at least 300 cases had a 3-year period of VATS cases, so you overcome the learning curve. And similar, you should have a proper prospective database for registry of all the cases. There's many findings in this paper. I'll just highlight a few things. Conversions overall 5.5%. Half of those were complicated related, half were technical or oncological related. And really many of the conversions was due to vascular injury. So that is the single most important factor. 41% of all conversions was due to a vascular injury. So you should be prepared for that, dealing with the major resections by VATS. So looking at the different major interruptive complications, there was 9 sections of wrong structure, 9 damage to the organ, it was mainly esophagus, 6 complications to the proximal airways, 9 complications leading to additional major surgery, and 17 leading to life-threatening condition, and there was 3 deaths on table. And this ended up having a major impact on outcome with quite a few dead persons within the 30-day and also the 90-day range. Actually, one of the findings was that the experience of surgeons was not that important for predicting whether there would be a complication or not. The only factor that did really indicate if you would have a complication, and you need to realize it when you do surgery, is if a patient had former chemotherapy, radiotherapy, or chemoradiotherapy. Then both from experienced and inexperienced surgeons, this is mainly done by experienced surgeons, you are in a high risk for a complication leading to a severe condition. We defined 46 cases with, which we looked into carefully, and this is one of the features from the paper, and just highlight that the majority of the vascular injuries is actually from the posterior ascending the A2 artery for the right upper lobe, the one that the Americans used to call the widowmaker. This ended up in some recommendations for avoiding major complications, and to highlight a few then study the preoperative imaging. And I think this is important because we can, of course, talk about how to deal with complications, but much more important is how to prevent it. So study the preoperative imaging carefully. Of course, proper timeout. What are you doing? Are you up to it? Who is in the room? Do you have all the instruments and so on? And nowadays work with a HD system. We work with an HD 30-degree angle camera, and now we have a 3D endosuite, which is also beneficial in my view. Proper deflation of the lung. Some anesthesiologists like to use bronchial blockers and similar. I would like proper double lumen tube so I can deflate proper, but also I can inflate and deflate during procedure if there's any doubt about the bronchial tree. Careful dissection, identification of all the hilar structures before you start to transect. Not, well, oh, that's the vein, just go on, transect it. Remove lymph flows if necessary. Identify all the major structures before you start dealing with one of those structures, try to transect it. Take 10-15 minutes to identify the anatomy and be 110% sure of where you are going and what to do. One of the lessons was that several cases had pulmonary hypertension, and in some of those cases, it was not identified upfront. So in my clinical practice nowadays, if there's a slight doubt about the pulmonary pressure, if there's any history of cardiac disease, I'll go for an echocardiogram to know the right-sided pressures, to know if there's pulmonary hypertension. If you then have a problem, want to stitch it, and you are up to stitching things by that, then clamp it before you try to do it, not just try to do it on freehand. Be ready for conversion and the fastest decision on converting if needed. So have a proper plan for this. And we should still bear in mind that the most important person's intrathoracic surgery is the patient, it's not the surgeon. So looking at postoperative complications and what indicates, we made a paper a few years back where we looked mainly on the fluid measurement, and the conclusion of this paper was that up to half a liter of fluid a day, as long as it was non-chyle, non-blood, then you could remove the tube. But interesting concerning air leaks was that almost half of the patients had the tube removed on day 1, and the majority of the patients were discharged just after the day after the tube were removed. In this paper, which is now some years back, we had a length of stay of 4 days. Nowadays, we are down to a length of stay after a vascular breakthrough median 2 days only. Complications leading to readmission in this paper, reintervention, there was really a few complications only related to fluid, but we did see that 11% had an air problem and 6.5% had extra treatment due to an air leakage. And we did identify actually quite a few that had it during the follow-up, readmitted to the hospital with lung collapse or a major pneumothorax at the 2-week outpatient follow-up. So you need air leaks, as concluded by many of the other presenters, are the major problem. And how then to deal with the air during procedure? Then the next paper I will highlight is this one, where we did a randomized study with 230 patients looking at the effect on suction level on the length of stay. So normally it's water sealant in the old days. See for an effect, they are not sure. So going to a digital device. In our clinic, we have 24 units of Medelas to pass, so we use that for all our patients. And traditionally, we had a suction level of -10 as long as they had the tube. So we randomized those patients for either -2 or -10, and then looked on drainage duration, air leak, pneumothorax, length of stay, and complications. So it is a open randomized study, power calculation with 18 hours of difference, sample size 230 vasculopectomies, only vasculopectomies. Overall surgical time, 1.5 hour, median drainage duration, 44 hours. What was interesting is comparing the two groups, the -2 centimeter of water versus -10 centimeter of water, the duration of drain, the time until there were no bubbling, no air leaks in the tropas, and actually the amount of fluid drained was significantly shorter in the -2 group than the -10 group. And if you see there's a tendency to less prolonged air leaks more than 5 days, and the tendency to length of stay should be shorter. Here's the curves for air leak duration on the Topaz reading, with the red one being the low suction and the green one being the higher suction. And in some levels, there are no overlap at all. So in this paper, we concluded that low suction level reduce drainage duration, gives shorter air leak, and reduce fluid amount. And there's a tendency for less prolonged air leak and a tendency for shorter air leaks, for shorter lengths of stay, excuse. During surgery, how should we then deal with the parenchyma? Well, facial edge technique has been discussed in detail. So now don't touch the visceral pleura at all. Just stable it. Form on like this is 2 pictures from an upper lobe lobectomy. In the early days, we sling the fissure and stable it. That meant we had to do a dissection to define the channel where we could sling it. Now just stable it. And we do really a no touch technique. So I don't use any clamps at all on the long parenchyma, especially not on the long parenchyma, to stay inside, because that can make scars. And actually the long parenchyma is a film in itself to cover the lung tissue. And then mentioned several occasions, high-low first, fissure last technique. And actually, we have also learned quite a few things from lung volume reduction surgery. We didn't do that many cases, but we have reintroduced our program for the last 3 years, and now we do like 40 to 50 cases annually. And it learns you a lot about how to deal with fragile patients. understand the anatomy and physiology of the emphysematous patients, doing limited resections, careful re-expansion of the lung, careful handling of the tissue. So one of our lessons there is that we now, for fragile tissue, use electronical staplers, so you don't do it abruptly by your hands. This no-touch technique, not dissecting in the fissure. We have used covered staplers. We don't use them any longer, and then we have learned something about how to deal with air leaks afterwards. I said bottle staplers is, in our opinion, now outdated. We are very fond of the tri-stapling technology because then you have a gradual stress along the staple line because the different heights of the clips in the stapler. So we only use tri-stapling technology now. We don't have any of the old technology at all in our theaters any longer. We have tried to see if we could avoid staplers using ligature or other energy-based devices to transect fissure, and that's not a good idea. So simple as that. Then, of course, as also mentioned, in some selected cases, you can stitch if you have a major air leak, or if you have some area where the floor doesn't cover it and you see bubbling by your water sealant test. And I use it quite often and maybe stitch it and then cover it afterwards with some other agent to cover it and to keep it intact. And what I use nowadays, it's very simple, is the V-lock, which is a suture with some hooks, small hooks on, so you don't need to tie it at all. It's really easy and simple to use by VATS. Interbronchial valves have been mentioned by Alan. I think we have done around 5 cases with prolonged air leaks where we couldn't stop it, but this is not really a first choice. It is the last option. You have discussed sealants in several of the presentations, and this papers have already been presented. There was an older one saying that it should not be used routinely on every patient, but in selected cases. And then the European Society of Thoracic Surgeons Delphi analysis have been presented already, saying from the European surgeons that there is a need for having some sealant available, and it should be a dedicated lung sealant. It should not be a vascular sealant. By bleeding, we use something to dress it with, and it might typically be the Tacoseal. This is actually a major bleeding from a pulmonary vessel from the pulmonary artery after right upper lobe lobectomy. It was A2 bleeding and couldn't really do anything but dressed it with the Tacoseal, as you see in the last picture, covered it, and the patient had a total uneventful postoperative course. Tacoseal does have a CE marking for air leaks, but it was based on this paper, a multi-center study many years back, concluding that there was a few hours shorter drainage time, but actually no difference in length of stay in hospital. So the indication is not that strong from the study. But anyway, it did get their CE marking for using Tacoseal for dealing with air leaks. We don't use it that much more, but here's a few cases used. So, but for bleeding, it might be beneficial. Then for the Progel that we have discussed, old studies showing that there are 2 randomized studies. This is an old American one showing that it gives a benefit in air leaks and in hospitals stay, and the other one was just presented before me, so I'll jump over it, but a nice study. So we use Progel if we cannot deal with the air leak in other ways. And one of the advantages to me is that it's easy to take out. It takes the nurses only 2-3 minutes to deal with it, and you can apply it. You don't need, like the Vivostat, to prepare it well before. And actually, the applicator is quite long and easy to use by VATS. As shown here, the extended tip, you can just bend it like you want, put it in one of your incisions and spray it over the target area. Shown in those few pictures here. Ending up having a picture like this, where you have like a rubber coverage over the area dealing with the air leak. And we do use it not routinely, but in selected cases. So in conclusion, looking at our algorithm when difficult surgery is there, first of all, careful surgery, no touch technique, don't clamp, don't dissect in the pleura at all. We address air leaks carefully during surgery. At the end, then only one tube is a size 24. And we do use targeted pain control so the patient are able to be mobilized and having physiotherapy, avoid epidurals, avoid morphines that will sedate the patient. We don't do any x-rays any longer. We use to pass on old patients, and we don't care about fluid amount as long as it's not blood or chyle. Then you remove the tube when there's no air leaks. Just one x-ray before the patient is discharged. Some patients go home even the day of the tube removal if they live nearby and the social situation indicates it. Then the patient had a phone call by the wardens a few days after discharge to see if everything okay, if they're fine, and they see the patient 2 weeks after surgery, planning the future, and that's the only outpatient visit by the surgeon. If we have problems in bleeding, try to control it by stapling or using the energy-based devices shown in the first slide. Maybe stitch it by suture, and if you cannot control it by surgical means, then we use either tackle seal or nowadays more and more the VAZ hemostatic patch because it's easier to deal with in VATS where the tackle seal disintegrate really easy. The VAZ is much more stiff and easy to handle. By major air leaks, try to stitch it by suturing and use glue, that is Pro-Gel. And if that's not enough, then we need to do more resection by stapling to close the area, and finally use tackle seal, maybe tackle seal and Pro-Gel. And if nothing else helps, then the pleural cells or doing a pericardial fat flap with a vascularization to cover the area. In the case of major bleeding, then we do have vascular clamps on table, as you see on the left side. So we don't have the tray for open surgery there any longer. We have a conversion rate of less than 1% or 1% now. So we have the two vascular clamps at the table of the scrub nurse, and then have the tray with this red sign in the room, and the floor nurse must never leave the room. She should be there, be ready to open this and hand it over within 1 minute, and then you can expand your tilt incision, and you can do a conversion within 1 minute if needed. And if you then have the bleeding, then first of all, a sponge stick to compress, and then actually just compress for a while. Be aware of the situation of anesthesiologists. Are they well in front of the situation? Do they need more manpower, more blood in theater? Does it need extra drugs, maybe an extra line? Give them some minutes to prepare things if you can control it with a big sponge stick. Get an extra suction with large diameter so you can really clean the cavity. And you should be aware of that you as a surgeon is the most important person there, and you should stay calm and take leadership and control situation. If you panic as a surgeon, everybody will panic and it will end up in a disaster. Not be afraid of calling in an experienced colleague. So you're two senior surgeons doing the case together and you can help one another. And then if you cannot control by this, then try to clamp the hilum through the tilt incision. Actually with that spoon-shaped clamp you did see, when you have taken the wean, you can clamp the whole hilum with that control situation. And then by conversion, expand the tilt incision. You can convert within 1 minute. So that was some thoughts about how to deal with complicated VATS cases. Thank you for your attention.
Thank you, Dr. Hansen, for your excellent presentation. And now I'd like to introduce the last speaker, who will speak about effectiveness of and safety of hemostatics and the sealants, view from the bedside. Nancy, experience. Stefan Renaud.
Thank you for this nice presentation, and thank you to Professor Cardillo for inviting me to this really interesting webinar. How to speak after this very famous and experienced surgeons. But so I will try to provide you our experience in Nancy on the use of hemostatic sealants in lung resections. So here is my disclosure slide, sorry, with so I'm lecturer for Bard, but I think I'm quite objective. So it has already been said a lot of time and extensively discussed. I think that air leak is something really interesting for thoracic surgeons, which is reflected by this webinar, and by the increased number of publication on this subject in the last decades. So, as you know, there are consequences of prolonged air leak, which are increased ICU readmissions, pneumonia, pleural empyema, of course, the patient discomfort linked to the drainage, an increased hospital length of stay, and a delay in resuming activity, leading to an increased cost. So our experience in Nancy is based on a particular situation because it's a small unit with only 12 beds. And last year we performed almost around 650 surgical procedures with around 300 major resection. And so we have a 30 to 40% daily bed rotation. So we need our patient to get out the hospital, unfortunately, really fast. So to optimize this major rotation, we had two targets, the air leak, and we were not only concerned by the prolonged air leak, but by the air leak itself, included on day 0, and of course the chest tube outputs. So we try to act on these two targets by using in a prophylactic manner. So the sealant PEG, also known as Progel, and an hemostatic powder, the Arista. The other reason why we don't use it only in specific patients is that there's not a strict correlation between the perioperative and the post-operative leak. And again, because of our situation, we can't keep patients in our hospital for many days, and we never deliver patients at home with the chest tube. So here is a quick example of what we do. So this is a right upper lobectomy performed by VATS. So we mainly perform in case of VATS the fissure-less techniques. Sorry, there's always a bit of oozing, as you may know, on the hilum and on the area of the lymphadenectomy. So we apply the Progel on the stipple line. So we try to go back and forth. And then we're gonna put the hemostatic powder. So in this video, you will see it in the 4R station. So quite easy to put, quite easy to apply. Another example here for left upper lobectomy, again fissure-less. So again, bit of using at the end of the surgery, and we have more and more patients with antiplatelets or anticoagulative treatments. So we try to decrease the risk of oozing and the blood output, within the 24 hours following the surgery. So we put this hemostatic powder on the hilum in the areal lymph node dissection. And then again, that's almost done. And then again, our sealants on the whole suture line, and that's it. So this is I will show you a few data of this study because it's still an ongoing study and with still a statistical analysis. So of course we had our local IRB approval. It's a prospective database from which we did a retrospective review. All patients had an anatomical resection for benign or a neoplastic disease, and were excluded patients who had undergone a wedge resection or a pneumonectomy. Of course, for studied demographic characteristics, the type of resection and its location, the presence or not of pleural adhesions, the use or not of sealants, the length of postoperative air leak, and we define the prolonged air leak has an air leak superior to 5 days, the less of hospital stay. And we assessed the risk of postoperative air leak by the IPAL, and Dr. Brunelli already extensively discussed this subject, so I will stay a lot on these slides. And so just a quick point. So thanks to the IPAL, we're able to define 6 categories of patients with a risk of prolonged air leak. So patients with a very low risk, moderate risk, high risk, and very high risk of prolonged air leak. So we decided to pull these patients into a low risk and a high risk of prolonged air leak. So far we have something like 220 patients with a mean age of 65 years old and a pretty low rate of prolonged air leak in the whole cohort, since we had only 8 patients, around 3.5%. So our cohort was mainly composed by male, and around 45% of patients benefited from a sealant. The groups were mainly comparable. The main difference were on the type of access, with no open thoracotomy in the sealants group. Same distribution of IPAD score between the 2 groups, and more segmentectomies in the sealants group. So here you can see the duration of the air leak according to the sealants used. In blue, the patient who had sealants, and here this box plot were the patient who didn't benefit from sealants, with a median leak of 0 day in case of sealants, and 2 days in case of no use of sealant, with an interquartile range of 3 days. The rate of prolonged air leak, so more than 5 days in case of use of sealant, was 2%, only 2 patients, and was pretty low too in the other group, with only 6 patients, around 5% with no significant difference. When we had a look to the air leak according to the group of IPAL, the median of the air leak in case of use of sealant was 0 day, regardless the IPAL score, and was significantly higher in case of use of no sealant, in particular with 2 days with patient in high risk of air leak. This had consequences on our length of stay, since the hospitalization was divided part 2 in the sealants group, around 4 days, including the pre-op days, post-op D0, and of course the post-operative days. In our experience in this cohort, of course, it's only a result in univariate analysis, but the risk of air leak without the use of sealants was 2.07. Concerning the hemostatic powder, all the patients in the sealant group had hemostatic powder too. On this data, we have a lot of missing data for the hemostatic powder, since around 50% of the data of the chest tube output are missing. So we can't make any strict conclusion, and around 50% of the patient had antiplatelets or anticoagulation therapy in our cohorts. There are no significant difference on the chest tube output on post-day 1. There was a trend toward the lower chest tube output in case of the use of hemostatic powder, but without significant difference. But again, probably too many missing data and too small groups. So of course, this study has limitation. It's a single center cohort study, and with a low level of evidence, since the groups are not randomized. It's a small cohort, and the impact of the Fisher-Last technique in the sealant group can be excluded. And I already told you there are important missing data, in particular on hemostatic powder, but it's an ongoing study, and we are trying to collect retrospectively this data, and few more comorbidities which could have probably impacted not only the air leak, but the length of stay, particularly emphysema, things like that. So in conclusion, in our cohort, PEG seems to be associated with both decrease in post-operative handling and length of stay in case of prophylactic use. For hemostatic powders, so far, we are not able to conclude on our cohorts. And it's an ongoing study with forthcoming medical economics data, and more patients. Thank you for your attention.
Thank you, Stefan. I don't know at this point, thank you for your outstanding presentation. I would like to ask my co-moderator, Professor Muriana, if you want to add some comments, or we can go directly to some questions. Giovanni?
We have some question in the chat. The first by Isabella Dracci is the target area for Progelli all the suture line or broader? And one who can...
Well, I have some experience in using the Progel, and I try to apply it on a quite broad base, so it really sticks to the lung instead of having it really centralized, and there's a risk that you get a tear, you get an air leak next to the Progel.
Okay. Another comment is advantages in the use of the novel PGA sheet interoperatively.
So we don't really use it in Nancy in case of majorization, so I don't have a lot of experience.
There is any panelist who have this kind of experience? I don't have it, to be honest.
No, I don't have it either.
Yeah. Well, perhaps I could comment. I mean, I don't use it myself, but NeoVeil, as you know, it's mainly our Japanese colleagues use it a lot. The Japanese tend, in almost all their operations, whether they're doing a pneumothorax or a lobectomy, a segmentectomy, they like using NeoVeil, but it's never in isolation. It's always with an adhesive. So they use something like a fibrin sealant, and they apply the NeoVeil over the top of that. They report very good results with it. Even with, when they do segmentectomies with no stapling, they claim very good results. What we don't have at the moment are any comparative studies to say how this NeoVeil technique compares with other sealants and other techniques.
There is other comments as from Eric Hansen to all panelists. I believe that Eric, probably you can say directly your comment.
There was a question about economics, and it's different from country to country. And by us, we get a fixed price, and it is around 12,000 euros for dealing with a surgical resection of a lung cancer. And then it's only if the patient stays more than 3 days in the ICU that we get extra payment. In the same time, we have a lack of beds, a lack of nurses, and sometimes our surgical activity is actually limited by the size of the ward. And therefore, for us, fast tracking and dealing with the complications and avoiding the complications is an important matter to do our cases. So it's not just beneficial for the patient to have fast track with all those benefits and having a fast recovery, but actually from an economical point of view, we need to fast track the patients pretty much also as the Nancy experience, not as extreme as that, but getting the patient out of the beds, out of the hospital, mean that we can do more cases, and there's a need for that.
Other comment? Giuseppe, I see that you answered just in Q&A, but probably you can add your comment. I can read, but I believe that it's much better if you give your comment regarding this particular aspect. The microphone, please.
The economic aspect was highlighted by Henrik, and is the same, I think, all over Europe. We get the reimbursement for disease, not for what we use for the patient. So not no matter the device we use, we can use high expensive device if we believe that they are cost effective, of course. And if we cut the days of stay of patient, we can do more patients. So it's very good for our hospital, for our management. So it's so we have to take a balance between the expenses, of course, and but of course at the center of our work is the patient. I have seen a very nice slide in which we put at the center of our job the patient, not ourselves. That's of course the same. And I know I don't know if there are other questions from the panelists before I close. I don't know. I think is there any question, Franca, from you or your co-chair or everybody else?
But I believe that it would be very interesting if maybe Alan and Alex, Alessandro Brunelli, can give, or Stefan can give some comments about this particular aspect, considering that we have, I suppose, a different management in terms of money and reimbursement, given that Alan is in the different area and Alessandro Brunelli is in UK, that we know now is with the Brexit situation is a little bit different. So I suppose that the healthcare will be managed in a different way. And again, Stefan, in France.
No, if I can start, we just we are in UK. We just left the Europe, but still are similar in the financial reimbursement system. So it's basically a DRG and a fixed rate, not completely fixed rate based on the type of procedure and comorbidities and complication, with similar rate as those as Henrik, basically. So for a lobectomy is probably 11, 12. For an uncomplicated lobectomy is around 12,000 pounds. There is no difference. Obviously, we are monitored in the expenses on what we use. Yes, they will. We get each month a detailed report from the financing and account department. Each department and each surgeon get a report on income and expenses. So far they have not limited us in any way. So I'm free to use energy devices, any number of staplers or sealants if I think clinically is appropriate. But I expect in the near future, considering the financial problems that we all had, and including the NHS, that will start counting down to the penny what we spend, and we'll probably need to justify. It's becoming increasingly more difficult to, for instance, try new devices, new products, and everything need to go through the procurement department, and you need to justify, make a business case. It's not even for free. You cannot just try a new product even for free without the authorization of the financing department because of previous contracting with other companies, etc. So yes, it's becoming stricter, but in general, the system is similar to what Henrik mentioned in Denmark. Yeah.
And what about in France, Stefan?
I think it's quite the same in France. So we have a fixed price for every procedure, but we can get extra pay depending on comorbidities mainly and complications a few times. And yes, so far there are no real limitation on use of products and device in the OR. If just like in UK, we show that it's cost effective. And the more patients you operate, the more money you have for the hospital. So if it's cost effective, there's no real limitations.
Okay.
Yeah.
I suppose that, yes, Harlan.
Yeah, I'll just add a very quick note. I think in places where I work in China and Hong Kong, we are actually costed for each element, every item we use. However, the thing is, if you look at, if you use a piece of Tacosil, or you use an extra stapler, or you use a sealant, how much does that cost? And if you go by the studies that we've already seen in this webinar, every time you use one of these products, you're potentially saving 1 or 2 hospital days, of stay. So, and that probably costs more than just a piece of Tacosil or a sealant. So in the ultimate, if you use that, you're actually saving money by reducing hospital stays. It works out. So I don't think it really matters too much in the overall scheme of things.
Thank you, Alan. Giovanni, do you want to ask something?
I think we'll leave to speak Giuseppe about the conclusion of the session.
Yes, I just want, if it's possible, I'm so sorry.
Yeah?
Yes, because there is some minutes. I would ask to Alex, I'm sorry, just to Alex. I have seen that there is in your presentation, it was a great presentation. There was a real, excuse me, because, okay. I have seen during your presentation that there is no real difference between open surgery and minimally invasive surgery. So my question here is if among the other factors, it has been taken into consideration the skill level of surgeons, and has this had an impact on the incidence of the air leak? Or if no, if you think that this is important?
Well, in all studies comparing VATS or robotic or minimally invasive, whatever, versus open, obviously these are all retrospective studies, often multicentric, and I think, the level of experience play a role, but also it's also difficult to compare cases with cases. In my opinion, the experience of the surgeon count, but on the other hand, in the majority of hospitals or teaching hospital, or generally also the case mix of patients varies with the experience of surgeons. So usually the most experienced surgeons get the more complicated, complex, high risk patients, while the junior they get probably the low risk, simpler cases with better pulmonary function, low risk of mortality. So it could be sometimes a paradoxical finding that you find increased air leak or complication in experienced surgeons, simply because they operate on higher risk patients. So, but if you take the same type of patients in terms of case mix, you match the patients, and probably the experience of surgeon does count, in the learning curve of a minimal invasive approach, and how you dissect the hilum, how you approach the fissures, how gentle you are in how you manage the lung. Sometimes you see, some surgeons are very aggressive in pulling the lung, and using graspers. Some other, are, using peanuts in a very aggressive way. So I think it matters. It matters. It's very difficult to analyze though, and to prove it.
I believe that we do, especially if we consider robotic surgery and
yes.
as minimal invasive, because this is a very important point, considering that there is don't have tactile feedback. Maybe.
Oh yes.
Okay. Yep. So I stop. I'm so sorry because we don't have enough time. There was another question to Alan, but maybe we will do privately. So I would ask to Giuseppe to conclude this section. Thank you to all the panelists.
Hello, can you hear me? Okay. Yeah. I would like to thank all the panelists. Just one word of answer to Alex about the juniors. In my opinion, juniors maybe take more attention to be gentle with the lung than we as senior are. That's my opinion when I say, I think that I don't trust sometimes a smaller leak. My juniors trust much more than me. This is my personal opinion. Of course, it's not for all, but it's my personal opinion, doing the chief for unit of thoracic surgery. And closing the webinar, I would say that this webinar has shown that prolonged leak and hemostasis affect the outcome of patient. That's clear. And of two, much, however, we have to know that this complication should be prevented during surgery and must be treated after surgery, because they are not a small problem. They can be a big problem for the patient. Many thanks to all of you for the attention, and we hope to meet in person very, very soon. Bye-bye.
Thank you very much. Bye-bye.
Bye. See you. Bye-bye. Thank you, Giuseppe.
Bye. Grazie Giuseppe, grazie a tutti.
Grazie a voi. Bye.
Arrivederci.